Please rise for the procession. Please remain standing for the national anthem of Sri Lanka.
Sri Lanka Mata, Atta Sri Lanka, Namo 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 Mata, Sundara Sri Tarini. Surani Ati Sobhamana Lanka.
I invite the following dignitaries to the stage. Dr. Ananda Vijayavikrama, President, Ceylon College of Physicians. Professor Asita De Silva, Orator. Dr. Kishara Gunaratne, Honorary Joint Secretary, Ceylon College of Physicians. Dr. Nilanka Pereira, Honorary Joint Secretary, Ceylon College of Physicians. To start the proceedings, I would like to invite Dr. Ananda Vijayavikrama, President, Ceylon College of Physicians, to introduce Professor Asita De Silva.
Good morning, ladies and gentlemen. Today, Dr. Cyril Fernando Oration of this annual conference will be delivered by Vidya Jyoti Professor Asita De Silva. Professor Asita De Silva is a clinical pharmacologist and is currently the Senior Professor of Pharmacology and Director Clinical Trials Unit at the Faculty of Medicine, University of California. He holds a doctorate in clinical pharmacology from the University of Oxford and is a fellow of Royal College of Physicians, London. His research interests have focused on clinical trials in neglected tropical diseases and major non-communicable diseases. He has published more than 65 papers in scientific journals, including NEJM, Lancet, and JAMA, and has delivered many orations and invited lectures. He has received presidential awards for medical research on numerous occasions and is a recipient of many prestigious international research grants. Professor De Silva received the National Honor of Vidya Jyoti in 2019 for its contribution to medical research. On a different note, the third Dr. Cyril Fernando Oration was delivered by Professor Asita's father, Dr. P.T. De Silva. And on a personal note, for the last 5 years, I had the opportunity of working with Professor Asita, where he's the chairman of the National Medicines Regulatory Authority. And under his chairmanship, it was an immense experience for me. And I saw his dedication, commitment, and the scientific way of looking at medicines regulation. It's indeed a pleasure to award the Medal of Oration today and inviting you to deliver this oration.
Good morning, ladies and gentlemen. I'm very grateful for the very kind words of introduction from the College of Physicians President, Dr. Ananda Vijayavikrama. I'm very grateful for the very fawning kind of introduction you made me, especially in relation to the NMRA. The two of us have worked for more than 4.5 years now. He's a member of the board. He's credited to be one of the key authors of the the NMRA Act, which I personally believe is one of the most beautiful pieces of legislation this country's national medicines policy has ever seen. And it's indeed a pleasure, Ananda, to deliver this oration under your presidency. President of the College of Physicians, members of the council, members of the family of late Dr. Cyril Fernando, ladies and gentlemen. Dr. Cyril Fernando was born on the 30th of April, 1900 in Colombo and passed away at 55 years in November 1955, probably a premature death. He was educated at St. Benedict's College, Colombo 13, and University College Hospital, London. He graduated MBBS in 1926 and passed his MRCP London soon after. He did so well at this examination that he was excused from the final viva. On his return to Sri Lanka, he joined the Department of Health and became medical registrar at the Colombo General Hospital. In 1929, he went back to the UK and completed his MD exam. He was awarded the gold medal for the best candidate of the year. On his return to the island, he was posted as assistant pathologist at the General Hospital Colombo and later physician in charge of the OPD, and in 1934, visiting physician General Hospital Colombo. Dr. Fernando is known to have been a great clinician and a diagnostician. He was held in high esteem by his colleagues and loved by his patients. He was an active member of the Ceylon Medical Association, being its honorary secretary, honorary treasurer, vice president, and in 1948, its president. He was an active member of the Ceylon branch of the British Medical Association. For his services to medicine, he was honored with an OBE in 1949 and an MBE in 1955. His main clinical interests were acute rheumatism and rheumatic heart disease. As a person, he has been a great friend who could enliven any gathering with his collection of anecdotes. A very sociable, good club man, and a skilled billiard player, I've been told. Dr. Cyril Fernando was way before my time. But whichever the galaxy of medical stars he is currently in and looking down at us, I feel he must like me personally because this is the third Cyril Fernando oration that the college has honored me with. And I hope my oration this morning on combating burden of cardiovascular disease through innovative strategies to improve blood pressure control, to studies done in my Center for Clinical Research in the University of California, will do justice to the memory of this great physician. Ladies and gentlemen, raised blood pressure is the biggest contributor to global mortality. It's responsible for 18 million deaths each year, and unfortunately, 80% of these happen in low and middle income countries. It's the largest cause of disability-adjusted life years, which includes 7 million premature deaths, again, low and middle income countries being disproportionately affected. In our region, high blood pressure accounts for a third of age standardized deaths, and a higher disease rates are seen in younger age groups with greater loss of productive life with serious, probably serious economic consequences. This comparative risk assessment of health loss related to 79 different risks and different risk clusters, including behavioral, occupational, and metabolic, from 1990 to 2015, there's a 25-year period involving approximately 9 million people in 154 countries, carried out by the Global Burden of Disease Risk Factor Collaborators, showed the global exposure to traditional risks of poverty, such as childhood undernutrition, decreased by more than 25% over these 25 years, whilst the global exposure to risk factors such as high body mass index increased by up to 25% during the same period of time. These are the 10 leading contributors to global DALYs, with hypertension right on top, and in 2015, responsible for an estimated 212 million DALYs. It is true in most parts of the world, except in the poorest countries in the world where still childhood undernutrition and unsafe water continue to be the biggest risk. In most other parts of the world, blood pressure remains the biggest risk. Sri Lanka also has reported through numerous studies, number of prevalence rates. These 4 studies, Neelika Malavige's, WHO, Anuradhini Kasturiratne faculty, and Prasad Katulandi in Colombo, have reported prevalence rates of hypertension in this country ranging from about 20 to 30%, which means 1 in 4 or 5 of us are hypertensive. These two meta-analyses of prospective studies, one done in Europe and the other in Asia Pacific, looked at the importance of systolic blood pressure as a risk factor for cardiovascular mortality, stroke, and ischemic heart disease. What I'm showing you here are the associations between 4 to 5 blood pressure indices corrected, adjusted for smoking and alcohol, smoking and cholesterol with the risk of cardiovascular death. As you can see, throughout middle and old age, blood pressure is directly and strongly linked, related to risk of cardiovascular mortality without any evidence of a lower threshold up to a systolic blood pressure of almost 115 millimeters mercury. Hypertension, however, was not always considered a disease as we know it now. To give you a high-profile example, this is President Roosevelt, flanked by two equally famous people, in Yalta after the World War II, was given a clean bill of health by his personal physician whilst recording a blood pressure of 220, 120. When he attended the Yalta summit to reorganize Europe or decide on the future of Germany, Churchill's personal physician wrote in his diary that Roosevelt seemed to have artery thickening disease and may not live for too long. In fact, in few months after the conference, he had a hemorrhagic stroke and died. This incident brought to the world's attention what a potentially deadly malady hypertension is. Unfortunately, during that time, there were not many effective medications to treat hypertension. Probably the time when Dr. Silva was practicing medicine. Even Roosevelt, of course, had low salt diet and phenobarbital massagers. But the story is very different today. We have very effective medicines to treat high blood pressure. This is a timeline of the major hypertension trials from 1967 to 2015, which have established clearly the morbidity mortality benefits of controlling blood pressure. Starting from the Veteran Affairs Cooperative Study in 1967, the first ever randomized trial on high blood pressure, which recruited 143 people to look at the efficacy of reserpine, hydralazine, and hydrochlorothiazide, right up to the groundbreaking sprint trial in 2015, which has shown massive morbidity mortality benefit by bringing your systolic blood pressure down to 120 or below. All these have established the morbidity and mortality reducing value of controlling blood pressure. Unfortunately, however, despite randomized data clearly showing that blood pressure reduction significantly reduces cardiovascular morbidity and mortality, and despite the widespread availability of effective and relatively inexpensive medicines, more than 1 billion people in the world have uncontrolled blood pressure or non-optimal blood pressure. And in most countries, the best rates of control achieving target is 30 to 40%, which is shown in this world map, the global control rates for hypertension across the globe. Most countries have 40 to 50% at best. Those are the developed countries. But if you look at the ones in red, our part of the world, plus maroon in certain parts of Africa, the control rates of hypertensive patients achieving blood pressure goals is less than 25%. There is a global hypertension cascade of care, which is looking at the global picture as well as high income and low middle income countries in terms of awareness, treatment, and control. Less than 50% globally, less than 50% of people who have high blood pressure know that they have high blood pressure. And very disappointingly, the global blood pressure control rate among hypertension is estimated about 14%, and is an abysmal 8% in low and middle income countries, which probably has resulted in this scenario where it's an estimate 20% of global deaths are attributed to non-optimal blood pressure. And this is estimated to be growing at 2% each year. The common approach to blood pressure management over the last 5 decades or so, as we all know, has been the diagnosis of the patient and being commenced on monotherapy at a lower dose, reviewed in the clinics, dose up titrated after a couple of more visits, and then if that doesn't bring control, to add another drug, which takes many visits to the clinic as well as time, which a lot of experts believe is a recipe for undertreatment. If you look at the global hypertension cascade of care again, you will see what I mean, because control rates among those who are treated for hypertension globally is less than 40%, and in low and middle income countries, which we have like ours, is less than 25%. Why? Well, I don't think there's a direct answer or a single answer to this. But a lot of experts believe that in many settings, two major contributing factors are responsible for inadequate blood pressure control. One is persistent use of monotherapy, and the second is, of course, inappropriate lifestyles, poor knowledge about cardiovascular disease, and low patient compliance. There is therefore, Mr. President, a need to challenge the traditional paradigms that are unlikely to effectively address the cardiovascular disease crisis, and to develop innovative solutions, both in terms of clinical care as well as health system delivery, to improve overall outcomes for our patients. We conducted two large controlled randomized trials using innovative approaches, which I'll be presenting to you soon, one at the tertiary care setting and the other in the community, to try and improve blood pressure control among hypertensives in Sri Lanka. This meta-analysis, involving about 354 randomized controlled trials done by Nick Wald in London, reviewed the clinical pharmacology of 5 classes of antihypertensive drugs, and they reported that all these classes of antihypertensives, if used at the appropriate dose, brought similar blood pressure reductions irrespective of baseline blood pressure. And interestingly, 75% of the standard dose, 75% of blood pressure lowering effect was obtained through half standard dose. This is half standard dose, that is standard dose, and that is double standard dose. And that's blood pressure reduction, systolic blood pressure in terms of placebo. And you will see that 70% of blood pressure reduction is achieved with 50% or half standard dose of the usual medicines. They also reported that for most classes of the antihypertensives I'm showing here, thiazides, beta blockers, ACE inhibitors, ARBs, and calcium channel blockers, for most classes, half standard dose was associated with substantially less adverse events compared to standard dose. And also, the efficacy of these drugs in combination was additive, but the incidence of adverse events of these combinations was less than additive. Therefore, it's likely that using combinations of antihypertensive medicines at low doses will have multiple benefits. Additive benefits of multiple drug classes working through different pharmacological mechanisms to bring down blood pressure, low doses having low incidence of adverse events. And if we can produce fixed dose combinations, maybe even improve patient compliance and adherence to treatment, and very importantly, reduce physician inertia to uptitrate to higher doses, which we have seen even in our studies. And at present, several clinical guidelines currently recommend dual combination therapy for initiation treatment, but triple therapy is only for patients with severe hypertension and uncontrolled blood pressure on a maximal dual therapy. No trial has evaluated triple therapy at fixed dose combination, low dose fixed dose combination for early treatment or initial treatment of hypertension. So there's a doubt whether using triple therapy at the outset is useful. And that doubt was the basis of the first trial I present to you, triple pill versus usual care management for patients with mild to moderate hypertension, the TRIUMPH trial, which we conducted in collaboration with the George Institute for Global Health in Australia, with funding from the NHMRC Australia and the Global Burden for Chronic Disease. The objective was to assess whether a strategy of initial or early treatment with fixed dose triple combination therapy of telmisartan 20, amlodipine 2.5, and clothalidone 12.5 would safely achieve blood pressure control compared to usual care. We kept the inclusion-exclusion criteria very simple. It is a pragmatic study with real-world situation. Consenting adults who had these blood pressure parameters, systolic blood pressure of more than 140 and or a diastolic of more than 90. Of course, the threshold was lower if you had diabetes, the patients had diabetes or chronic kidney disease were recruited after consent. The patients were either treatment naive or not controlled well on monotherapy. The primary outcome measure was the proportion of participants in the study reaching or achieving blood pressure control as defined here. There were many secondary outcomes, including safety assessments. This is a basic or a brief design of the trial, which is a pragmatic trial, as I said, which we conduct in 11 urban hospital outpatient departments. Some of the investigators are in the audience this morning. We recruited 700 patients who either were treatment naive or were not controlled on monotherapy, and they were randomized to receive the triple pill or usual care. They were followed up for 6 months, which was the end of the study, with 2 visits at 6 weeks and 12 weeks, with the opportunity to up-titrate the dose, which is left at the discretion of the physician. We had 96% retention of the trial participants at the end of 6 months, which was absolutely remarkable. The baseline characteristics, as you can see in this table, were equal in both groups, indicating excellent randomization. Now, these are the key outcome measures. As I said, the primary outcome measure was reaching target blood pressure at 6 months. 70% of those who received the triple pill achieved their blood pressure target, versus 55% in the usual care arm at 6 months, a very significant difference. And this difference was seen from 6 weeks onwards. The difference was evident. The between group difference was very clear from 6 weeks onwards. At 6 months, the systolic blood pressure dropped by 29 millimeters mercury in the triple pill group compared to 20 millimeters mercury in the usual group, almost a 9 millimeter mercury difference in systolic blood pressure, and similarly, about a 5 millimeters mercury difference in diastolic blood pressure. Highly significant results. The adverse effects, there were no difference between the two groups in terms of serious adverse events or patient withdrawal due to adverse events. We published this in JAMA and concluded that early use of low-dose triple therapy, fixed-dose combination is safe, provides faster and better control of blood pressure compared to usual care. And these findings, we believe, strongly supports a strategy of early use of low-dose triple combination therapy in all settings. We also conducted a within-trial economic evaluation to assess the cost-effectiveness of this intervention, with Stephen Yahn's group in Sydney, and published his work in Lancet Global Health last year. Well, the cost effectiveness of the intervention will obviously be determined by the price of the medicine. We don't have a fixed dose combination of 3 medicines for hypertension at the moment in the market, so we wouldn't know exactly what the price is. But these are assumptions I have made here. If the triple pill, the cost of the triple pill would be the sum of individual pills, well, it will be about 16 cents for a day, that is in US dollar terms, which will give us an incremental cost-effective ratio, which is simply cost per life year gained of about $2,800, which may or may not be appropriate or cost-effective for Sri Lanka. But it need not be the case. There are generic brands of these medicines, and if we can produce a fixed dose triple therapy at a possibly 5 cents a day, then the incremental cost-effective ratio is an attractive $172. But if you can bring it down to 4 cents a day, well, there'll be a cost saving, which is unheard of in any healthcare intervention. It has also long been believed that rural communities are less challenged by cardiovascular disease risk. This 5-continent meta-analysis done by Salim Yusuf and his group in US showed otherwise. They looked at cardiovascular disease risk, events, even mortality in high, middle, and low-income countries, covering both rural and urban populations. What I'm showing you here is the existence of cardiovascular disease risk or the prevalence of risk in terms of inter-heart risk score. It's a score to quantify risk, which without taking laboratory parameters into consideration in high, middle, and low-income countries. You will note that the highest risk for cardiovascular disease exists in high-income countries and the lowest in low-income countries. But if you look at outcomes, cardiovascular disease outcomes, myocardial infarction, stroke, heart failure, all cardiovascular disease. The biggest burden is in low-income countries, and the lowest burden is in high-income countries. So low-income countries have low risk, existence of low risk, but the highest incident rates. So there's something that is not working in our risk mitigation strategies. And these meta-analyses also reported cardiovascular disease events and case fatality rates in, again, high, middle, and low-income countries, both covering rural and urban populations. What I'm showing on top here are the event rates. You will see again, the event rates are higher in low-income countries, all major cardiovascular events. And if you look at cardiovascular mortality, case fatality rates, they are also higher in low and middle income countries. But you'll also note that this is affecting more of the rural communities. The case fatality rate is high in rural communities and event rates are high in rural communities, which probably means our risk mitigation strategies do not reach rural people. That advised the second trial that we did to control blood pressure and risk attenuation in 3 countries running the same protocol in targeting rural communities, a cluster randomized rural community-based trial on integrated primary care strategies to reduce high blood pressure, which we conducted in collaboration with the ICDDR in Bangladesh, Aga Khan University in Pakistan, Duke NUS in Singapore, and the London School of Tropical Medicine and Hygiene. It was funded by a very generous grant from the Wellcome Trust, MRC, and DFID in the UK. And we did this trial with the principal objective to find out whether a multi-component intervention consisting mainly of, but not limited to, home health education provided by trained community health workers, plus blood pressure monitoring house to house and stepped up referral to medical practitioner by the same community health workers, plus training of the medical officers in those rural hospitals in evidence-based management of hypertension. In addition to usual care, these 3 interventions, in addition to usual care, would be better than usual care alone. And this model that we use just piggybacked on the existing primary healthcare structure. We only provided the training. The entire trial was delivered by community health workers through the primary healthcare system, mainly public health midwives. And they were delivered in the hypertensive individual houses. We published the methodology and the protocol in trials, but very briefly, home health education, which was delivered by trained public health midwives, took a standard message on nutrition, lifestyle, cessation of smoking and alcohol intake. Plus, they were trained to use Omron machines to assess blood pressures house to house. So home health education and blood pressure measurements using standardized measurement techniques and stepped up referral to health providers, that's medical officers in the region, through trained community health workers, all 3 countries, including Sri Lanka. In addition, we trained the general physicians, the general practitioners, the medical officers in those rural clinics on evidence-based management of hypertension using NICE guidelines, as well as assessing risk factors for comorbidities and risk attenuation. The research team had nothing to do with the intervention. We just did the training. It was a stratified cluster randomized trial involving more than 2,500 participants who had hypertension in rural communities in the 3 countries. It was for 3 years with a 2-year follow-up period. And again, being a pragmatic trial, the inclusion criteria was very simple. People over 40 years of age residing in the randomized clusters with hypertension, it is defined as currently diagnosed hypertensives who are on treatment right now, or a systolic blood pressure of 140 more, or a diastolic blood pressure of 90 or higher. The primary outcome measure of effectiveness of the intervention was reduction in systolic blood pressure at 24 months at the end of 2 years. And there were many other secondary outcome measures as well as cost effectiveness measures. We conducted this trial in Sri Lanka in the Putlam district, in rural communities such as Vanathavillu and Kaluragaswa. I must confess, areas I had never gone before in my life. We recruited 850 from Sri Lanka, from these 10 randomly selected clusters, which included, as I said, already diagnosed hypertensives. This is just to show you the general terrain and the area. One of our research coordinators doing the baseline survey, and this, I would say, the champion of the study, a public health midwife, going by bicycle house to house, delivering the home health message, home health education message, and measuring blood pressures in the selected communities. Very briefly, all 3 countries had 10 clusters each. 5 received the multi-component intervention. I'm looking at Sri Lanka right now. And 5 clusters were given the usual care, were in the usual care arm. And we recruited slightly more than what was necessary according to the power of the study design. In Sri Lanka, 2,308 community dwelling hypertensives were screened to recruit 870. What I'd like to highlight here in this chart is that at the end of 2 years of follow-up, we had more than 90% retention. More than 90% retention, which is absolutely remarkable for a community-based trial. And I'm very grateful for our research coordinators for achieving that. I'd like to spend a little time on the baseline characteristics of the groups. The intervention arm here, the 3 countries, all 3 countries, control arm here. There were no significant differences, statistically significant difference between the baseline. But I'd like to spend a little time on the characteristics of baseline characteristics of cohort from Bangladesh, Pakistan, and Sri Lanka. And if I were to point out, the Sri Lankan cohort of 856 had a higher mean age. We were older. We had a massive advantage in terms of literacy, 96% versus 30% in Bangladesh. And the prevalence of associated comorbidities was staggeringly higher in the Sri Lankan cohort, almost 40% diabetic, and about 73% had chronic kidney disease, which is defined as an eGFR of less than 60 ml per minute. And our patients, as you can see here in the bottom part of this table, had access to medicines free of charge. And they had access to medicines such as ARBs and calcium channel blockers, whereas in the other 2 countries, the main medication of beta blocker. So we were older, slightly fatter if you like, higher body mass waist circumference, more educated, had much more chronic comorbidities, had access to free medicines, and of the free medicines, first-line treatment recommended by NICE guidelines. But if you look here, you'll see that a large proportion of the patients in Sri Lanka, 65%, had uncontrolled blood pressure. And about 32% had poorly controlled blood pressure defined by a systolic of 160 or more and a diastolic of 100 or more. So more educated, richer, slightly richer, maybe fatter, slightly older, access to medicines, but poor control. So I think there is a difference here. I'm trying to point out that just access to medicine alone is not going to solve the problem of uncontrolled blood pressure. These are the main outcomes. The primary outcome was reduction of systolic blood pressure at 24 months. And this is systolic blood pressure on top and diastolic blood pressure at the bottom. At 24 months, systolic blood pressure fell by 9 millimeters mercury in those who received the multi-component intervention versus about 3.6 millimeters mercury fall in the usual care arm. Difference of almost 5.2 millimeters mercury between the interventions. Systolic blood pressure was similar, but the difference was less. At 24 months, those in the intervention arm had a diastolic blood pressure reduction of about 6 millimeters mercury, and usual care about 3, a difference of 3 millimeters mercury at 24 months. In addition, 53% in the multi-component, as the intervention arm, achieved blood pressure control, as opposed to 43% in the usual care arm. Now, these are results for all 3 countries. But if you look at the Sri Lankan cohort, I'm showing again in terms of systolic blood pressure, diastolic blood pressure from baseline change, and percentage of control. You will see that our level of control is slightly better. The difference in the reduction of systolic blood pressure was about 6 millimeters mercury, and diastolic about 4, and 58% of the people who received the intervention achieved blood pressure control, as opposed to 46. So we can argue and say, yes, Sri Lankan cohort did better through this intervention, but the study was not powered to look at individual countries and their cohorts for this effect. We concluded that this multi-component intervention that we delivered through existing primary healthcare infrastructure through public health midwife significantly improved control of blood pressure in rural communities. The benefit of this intervention for blood pressure lowering increased with longer follow-up. It was less at 6 months, more at 12, and wider at 24 months, indicating that there may be a longevity of the intervention effect. We have completed the economic evaluation. It's under consideration of publication, but the preliminary information shows that the intervention that improved blood pressure control would cost an additional estimated annual cost of about $11 per patient. But what is most important to this study is community health workers in the public sector who are responsible for maternal and child care can also play a very important role in managing high blood pressure. We published this work in February this year in New England Journal of Medicine and concluded that this multi-component intervention for hypertension care centered around proactive home visits, not clinic visits, home visits, by trained government community health workers through existing primary healthcare infrastructure can lead to a clinically meaningful reduction in blood pressure in rural communities in this country. Ladies and gentlemen, in summary, high blood pressure is the leading cause of mortality globally, and the most disease burden is seen in low and middle income countries. Despite the well-established link between blood pressure lowering and reduction of cardiovascular disease mortality, and the availability of effective and relatively inexpensive medicines, large gaps in blood pressure control remain, and about 20% of all global deaths are attributable to non-optimal blood pressure. Our studies had a relatively short duration of follow-up, maximum was 2 years. So these studies did not provide the required power to assess cardiovascular events as an outcome, whether reducing the blood pressure would translate to reduce myocardial infarction, stroke, and so on. But we know that a reduction of systolic and diastolic blood pressure in this range, 2 to 5 millimeters mercury, is associated with a 10% reduction of cardiovascular disease mortality. Therefore, our cost-effective interventions we trialed, including early treatment with fixed-dose combinations, triple therapy, and the use of primary healthcare system to proactively go house to house, to carry the message and also to make sure the loop is connected in terms of control and follow-up, may translate into substantial public health benefit. And we believe that there's an urgent need for effective implementation and scale-up, especially in low and middle-income countries where the disease burden is highest, to contribute to global action plan the objective of reducing blood pressure prevalence by 25% in low and middle income countries in 2025 or by 2025, and perhaps contribute to reducing premature death. I'm very grateful, Mr. President, ladies and gentlemen, to a lot of people who made this possible. I acknowledge the support received from the George Institute for Global Health, particularly Professor Anushka Patel, who even shared some slides with me. Investigators from Sri Lanka, some of whom are in the audience today, including Nirmali, who worked to make all this possible. The study participants, our patients, the medical officers in the hospitals, OPDs, nursing staff, and of course the trial steering committee and the data safety monitoring board, and the funding agency, NHMRC Australia, as well as the Global Alliance of Chronic Disease. I'm also very grateful to the support received from our collaborating centers to run the COBRA BPS trial, Aga Khan University, ICDDR in Bangladesh, particularly Imtiaz Jahan and Alia Nahid in Bangladesh, Tasin Jaffa and Eric Finkelstein in Duke and US, and Professor Shah Ibrahim at the London School. I'm very grateful to our primary healthcare staff in the Putlam district, starting from the provincial director, regional director of health, the NCD medical officer, the NCD divisions, the midwives, the medical officers, the community health workers. They were fantastic. Without their support, this would not have been possible. And in addition, of course, the NCD division in the Ministry of Health. The trial steering committee that guided us, and the data safety monitoring board, and the very generous grant received from the Medical Research Council, Wellcome Trust, and DFID in the UK. The Clinical Research Center, the Clinical Trials Unit in our faculty was established in 2009 to participate in large-scale population, clinical and health systems research with a focus on innovative, cost-effective, scalable healthcare solutions in collaboration with centers of excellence, with an interest in major NCDs and neglected tropical diseases. I'm exceptionally grateful to my research staff, the project managers, the coordinators, young men and women of science, for their dedication, for their hard work. Because of their hard work, we have been able to collaborate with the best centers in the world on equal terms. And finally, I hope this work presented today will show my delightful 18-year-old daughter in the audience that clinical research can be interesting, rewarding, and fun. Thank you very much.